Honourable Senators, we are meeting to finalize our study on Bill S-228, an act to amend the Criminal Code sterilization procedures. Our first panel has 3 members. We're pleased to welcome the Society of Obstetricians, Gynecologists of Canada, Dr. Deanne Francoeur and Dr. Lynn Murphy-Colbeck. Also joining us by video is representing the Canadian Medical Association is Dr. Margot Brunel, the President. Thank you for joining us here today, witnesses. We'll begin with your opening remarks before we move to questions from members, starting with the Canadian Medical Association, followed by the Society of Obstetricians and Gynecologists of Canada. So your presentation, please, Ms. Brunel from the Canadian Medical Association, a statement for about 5 minutes or so.
Thank you, Mr. Chair. Good morning. I am pleased to join you from the traditional territories of the people of the Treaty 7 region in southern Alberta and home to the Métis Nation of Alberta Region 3. My name is Dr. Margot Brunel. I am the president of the Canadian Medical Association. As a medical oncologist with nearly 4 decades of experience, I have led hospital departments, contributed to clinical research, and advised on national health policy.
Witness, Ms. Dr. Brunel, could you please open your camera? We're not able to see you here on the floor.
Is that better?
Yes. Yes, thank you. Please continue.
As a medical oncologist with nearly 4 decades of experience, I have led hospital departments, contributed to clinical research, and advised on national health policy. I have the privilege of representing physicians and medical learners from every corner of this country, and through them, the people for which they provide care. Thank you for the invitation to provide the physician's perspective on Bill S-228, an act to amend the Criminal Code on sterilization procedures. Mr. Chair, we appeared before this committee last year about the original Bill S-250. We expressed our support. We are here today to support Bill S-228 and further commend the clarity that updates to the wording bring. Bill S-228 makes clear that performing a medical act leading to sterilization without free, prior, and informed consent constitutes aggravated assault. This clarity can draw attention to the issue for physicians, patients, and law enforcement. The new provision can have meaningful influence on the importance of obtaining free, prior, and informed consent, and informing patients about the medical risks associated with medical procedures, including the possibility of sterilization if a physician must act to protect a patient's health or life from a medical perspective. This clarification could also result in improved prevention measures and more thorough investigations. The Canadian Medical Association condemns the abhorrent practice of forced and coerced sterilization. These acts are rooted in systemic racism and discrimination. They have caused irreversible harm, most often to Indigenous women, girls, and two-spirited individuals, and left a legacy of inequality and injustice in regard to human rights. The harms of the practice of forced or coerced sterilization, which seeks to control human breeding by denying births, are immense and carry forward for generations of those who have been subjected to a non-consensual sterilization procedure. The dark chapter in our country's history is not yet behind us. In the past, both governments and parts of the medical community supported these practices to limit birth rates in First Nations, Inuit, and Métis communities, in Black communities, and among people with intersecting vulnerabilities related to social and structural determinants of health, ethnicity, and disability. The Canadian Medical Association is committed to the highest standards of ethics and patient care. However, we must acknowledge our profession's role in these unethical practices. The medical and legal communities must stand together in an unwavering commitment to protect the rights and dignity of every person in Canada. If Bill S-250 was a step forward, the clarity of Bill S-228 is a stronger safeguard and an improvement. We support the amendments to the criminal code that make sterilization without free, prior, and informed consent a crime. This amendment is one critical step. It is still only the beginning of the work to be done. We must end systemic racism against First Nations, Inuit, and Métis people in our hospitals and across our health system. As we reform the system, we must hold fast to the pillars of medical ethics, treating every patient with dignity and respect, while recognizing vulnerability, supporting autonomy in health decisions, and confronting inequities in care. These principles can guide us to a system that is truly universal and just. The CMA fully supports the changes to the criminal code in Bill S-228. We look to a future where every person's rights are protected and where patient consent is always paramount. Our responsibility is to help ensure a health system that is a place of safety, dignity, and care for all. Together, we must ensure that healthcare providers are equipped to engage in culturally and psychologically safe reproductive health conversations with Indigenous patients. We commend the government for its leadership in educating the public on this important matter and for the unwavering leadership of the Survivors Circle for Reproductive Justice in supporting those most closely affected by this unethical practice. Accountability means ensuring these injustices of forced or coerced medical sterilizations are never repeated. This amendment is one step towards justice, and it obliges all of us to do more. Thank you.
Thank you, Dr. Bernal. And now we'll hear from the Society of Obstetricians and Gynecologists of Canada, Dr. Francoeur and Dr. Murphy-Callbeck.
Good morning, Mr. Chair, honorable senators. My name is Dr. Lynn Murphy-Callbeck. I am a maternal fetal medicine specialist, and I serve as president of the SOGC. I am joined by our CEO, Dr. Deanne Francoeur, who is also an OB-GYN. We are grateful for the invitation to appear to discuss this issue of profound importance. Let me begin with absolute clarity. The SOGC strongly condemns coerced or forced sterilization. No woman should ever be subjected to permanent contraception without her free, prior, and informed consent. Autonomy and consent in reproductive decision-making is a cornerstone of ethical medical practice and a fundamental human right. We issued an opinion in 2019 on non-coercive contraceptive care precisely because of the systemic racism and violations of trust that have come to light, including the tragic treatment of Joyce Echaquan and the broader revelations of the Truth and Reconciliation process. We must continue to acknowledge these harms and take responsibility as a profession. Our organization has taken deliberate attempts to confront these legacies and try to prevent such harms from happening. We have embedded training on consent, cultural sensitivity, and acknowledgement of past and ongoing medical harms into our accredited continuing education programs. The SOGC ensures that every physician who takes part in our courses receives evidence-based education that reinforces the principles of informed and non-coercive care. When it comes to medical harms that have been inflicted on Indigenous peoples in health settings in Canada, we have publicly acknowledged that historic, ongoing, and unacceptable harms have unfortunately taken place. Acknowledging these wrongs is an important step toward reconciliation and healing. In June 2024, we issued a public statement unequivocally condemning coerced sterilization. We recognize that Bill S-228 is presented as a measure to make explicit what is already covered under existing law, as coerced sterilization is already illegal and should never be performed in Canada. We also know that Section 45 of the Criminal Code already provides important protections for physicians in emergency situations. Our concerns, however, is about how this bill will be interpreted and applied in real clinical settings. Obstetrics and gynecology can be a high-stakes field where emergencies can unfold in minutes. In the middle of a massive hemorrhage or a ruptured ectopic pregnancy, physicians cannot pause to parse the fine distinctions of the law. Their focus must be on saving the patient's life. If there is even a perception that those life-saving actions could later be second-guessed as a potential criminal offense, hesitation becomes a real risk. And the consequences fall on the patient, who may lose precious minutes of care. There is also the concern that if procedures are perceived as criminalized, physicians may step away from offering tubal ligation to women who want one in their regular clinical practices, not just in emergencies. We have seen how this type of chilling effect has already unfolded in the United States, where legal uncertainty around reproductive health laws has led some physicians to delay or withhold urgent treatment for fear of prosecution. These situations have led to preventable deaths of women in the U.S. If physicians in Canada begin to question whether they could be facing up to 14 years in prison for providing emergency care to a woman whose life may be at risk, this could lead to similar dire consequences here. Our concern is not with the principle of outlawing coerced sterilization. We strongly support this. It is with ensuring that we do not inadvertently create an environment where physicians feel less secure in providing the urgent care that women need to survive and thrive. Senators, we share your goal to end the abhorrent practice of coerced sterilization in Canada. We also have a duty to safeguard women's access to timely, respectful, and life-saving reproductive care. Thank you for inviting us to speak here today. We would be pleased to answer any questions.
Thank you. We'll now move to questions from the senators, and we'll start on my left with the Deputy Chairs, Senator Batters.
Thank you very much. Thank you to all of you for being here today on relatively short notice, so we appreciate your important contribution here. To the Canadian Medical Association witness, thanks for your opening statement, and I just wanted to just say one thing. There was one point when you were sort of thanking the government for proceeding with this important issue, and this is actually a private senator's bill, not a government bill, and it's Senator Boyer, who's here with us today, that deserves the credit. It is not a government bill. So I just wanted to make that point because she should receive recognition for that. And to the witnesses from the Society for Obstetricians and Gynecologists of Canada, last time you testified before our committee on a predecessor of this bill, it was March 20th, 2024, and I just have the transcript from that. And at that point, Dr. Francoeur was expressing similar reservations and perhaps even greater reservations about this bill because of the potential criminalization, which of course this is an amendment to the Criminal Code of Canada. But at that time that you were testifying, this bill was substantially more wide-ranging and had a lot more potentially concerning elements for you as doctors in this. And now the bill has been really dramatically pared down, so it's really for a greater certainty to provide, as you were stating, I think in part in your opening remarks, Dr. Murphy, you were stating that you were more worried about what the implication could be, I think. So yeah, I guess I just wanted you to address that. Are you recognizing that this bill has been substantially pared down from what it was? And given that, does that make some of your concerns more muted on this one?
Président, je vais répondre, si vous me permettez.
If I may, I'll respond to that question. Thank you very much for the question. And here's my answer. Unfortunately, any attack on the women's reproductive and sexual rights, no matter how small or large, will in fact be an emulation of what's occurring in the United States. In the United States, they started by limiting the right to choose, and currently there are women who are dying from miscarriages because they can't get the gynecological services they need in ER operating rooms across the United States, because physicians must prove beyond any reasonable doubt, because abortion is now a crime in certain US states, that survival was no longer possible. So when you open the door even slightly to criminalisation, well, that has an impact on women's sexual and reproductive rights. And unfortunately, it is our misgiving and fear that there will be a misinterpretation of this. It might be misconstrued, and there might be a lot of fear around the fact that a physician might end up in prison for 14 years behind bars. And as Dr. Murphy-Colbeck indicated, we repudiate all sterilisation without consent, and we will go to great lengths to ensure that that never becomes a fact, a possibility, and we believe that it needs to be dealt with forthwith.
Started off with a comment about abortion and the United States, because of course in Canada we don't have an abortion law and haven't since, I believe, 1988, when I think I was in grade 12. So I understand your concern for a potential slippery slope, but here we have a senator's bill who she's trying to protect women in that they don't have this forced sterilization situation, and I can certainly understand that all of the people in your field who are doing their jobs appropriately, that's part of your job, is to ensure that they are, and to take steps if they are not. But at the same time, and I understand you're speaking about a slippery slope, but do you acknowledge that this is a considerably different element here that we're dealing with, and what it's doing is basically just reaffirming the fact that forced sterilization without consent, is just, it falls within the aggravated assault provisions.
Pour spécifier davantage.
Well, just to further clarify, one needs to make the distinction between sterilisation that has been planned for an elective surgery and one that is a matter of urgency. What we are concerned about is emergency situations where women are in a precarious medical state. They might hemorrhage, they may die, they're young, it's their first child, and unfortunately, the only solution, the last recourse, would be a hysterectomy after delivery. And hysterectomy is a sterilising surgery because you can no longer give birth or have a child thereafter. So in those particular contexts, we know that Section 455 was put in place in the Criminal Code to ensure that physicians would have the flexibility to make decisions without consent, because a woman is hanging in the balance between life and death. Of course, the family's opinion is factored in, but at those critical stages where every single minute counts, unfortunately, the physician might be in a position where they ask themselves, have I made the right decision? Might I be sued because I've performed this sterilising surgery, which was not the goal at the outset? But oftentimes in the operating room, before there's a planned hysterectomy, certain procedures are taken so that a woman's uterus will remain intact. But unfortunately, in 2025, there are still women who die from hemorrhaging in Canada. That's one example. In other examples, for example, an ectopic pregnancy that is breached, there's bleeding, and it bleeds in the stomach of the woman, and that requires an emergency surgery. And in fact, every other surgery is relegated to later in the day because the females may die from hemorrhaging shock, and therefore the fallopian tubes need to be removed. So when a woman is in an unstable state, there's consent, but it's not informed consent when someone is hanging in the balance between life and death, even if it's being perhaps potentially explained to them and what the potential ramifications might be. There's no time to ensure that consent, that the physician can go and delve into all the details. It's not like an elective surgery. Of course, the blood is being prepared, the anaesthetist is being briefed, and there are other considerations that are put in place. And that all happens very, very quickly. Now, the treatment is to remove the fallopian tubes, and that is a sterilising surgery at the end of the day. What do we recommend? We recommend the bare minimum? No, because we haven't gotten consent? No. We perform, if we don't notice that the fallopian tubes have been damaged, well, and if we determine later that we failed and we didn't get informed consent because the woman was hanging between life and death, well, we've made the right decision. That doesn't occur on a daily basis, but it does occur. And any woman who dies on the basis of a botched surgery or one that was postponed or delayed unduly because there's a fear of being sued, that's one woman too many in Canada. We already have the Charter of Rights and Freedoms in Canada, which prohibits non-consensual sterilisation because consent isn't possible. But it's our belief at the College of Physicians that they need to assume their responsibility in this particular matter and intervene when physicians proceed with non-consensual sterilisations. We believe what women say to us. This needs to stop, and we agree 100% with you on that.
Just a quick little follow-up on one part that you were mentioning near the end, and I was listening through translation, so I just want to make sure that I understand you correctly. Is it your understanding that the Charter of Rights protects women normally from this if this bill was not made law? Is that what you were saying?
Oui, parce que moi, je peux vous dire dans mon
Well, yes, I can speak from experience. I'm a pediatric gynecologist and I've cared for disabled children throughout my whole life, and there are parents who are desperate that ask for sterilisation because they believe that their daughter is not able to be pregnant, and we ask them if your daughter is not fit to provide consent, we cannot perform a sterilising surgery. That's what we teach.
I've got a number of senators, Senatrice Miville-Deschênes, Senator Prosper, Senator Boyer, Senator Simons, Senatrice Saint-Germain, Senator Payton, and Senator Tanna. So, well, please.
Merci, Madame Diane Francoeur, d'être avec nous.
Thank you, Dr. Diane Francoeur. I'd just like to reiterate what my colleague said. There is Section 45 that protects you in very clear emergency situations where the physician needs to take a decision in the possible absence of consent. Now, this legislation is currently drafted. Despite the fact that we are adding a definition, it doesn't change the substance of the legislation itself. And my takeaway from all of that is that we have to name things. We have to be explicit. Women who haven't filed complaints will be able to see that in the criminal code itself there is a naming of this particular issue. But we're not changing or amending the legislation. The Department of Justice officials have clarified that the law on assault remains the same. So this is very symbolic. It's important, but nevertheless symbolic. Now, you're opposed to that, whereas that could help certain women to really get a handle on the fact and understand that they have rights at the end of the day.
I'm just going to address just one issue that came up before with respect to the example of abortion. I don't think it's abortion. I think it's sexual and reproductive health rights. And when we criminalize that for women, then we often see that there's a withdrawal of care. So I just wanted to clarify that. No, I know. I just wanted to clarify earlier on that. It's women's health, I think, that we're more concerned about. Do you want to answer this?
No. Évidemment, il faut.
Well, of course, you need to see the forest and not just the trees, or vice versa. So I think that what concerns us is this slippery slope. And I admit, frankly speaking, that when we came here last spring, the situation has degenerated in the United States due to this criminalisation, which is now in the sexual and reproductive legislation affecting women. We believe that women need to be informed. We need to explain what sterilisation means. The fact remains that there are a number of women that will be faced with contraindications when it comes to using contraception, and they'll have no choice but to choose sterilisation or abstinence. So we want to be there to be able to help them as best we can. Now, that said, you have to consider the adverse effect of a potential slippery slope when it comes to the reproductive and sexual rights of women. Now, it's all well and good to draw a comparison with the United States, but when the possibility of committing a crime is there, you're going to second-guess yourself. And those delays will have an adverse effect when it comes to providing the necessary care to women. Well, I don't agree with you when you say there's a slippery slope vis-a-vis the United States. Our system, our laws are completely different. I understand that that helps you to back up your arguments, but we're not in the United States here. I just wanted to clarify that.
Prosper.
Thank you, Chair. Thank you to the witnesses as well for informing this very important dialogue and on this very important subject. My question, just in terms of clarity, and I'm grateful for the dialogue that just took place. Is it your opinion that Section 45 does not provide enough protection for physicians to warrant them to undertake those necessary procedures subject to this bill? For example, do you think that this chilling effect amongst physicians could be mitigated by knowing the full breadth and substance of Section 45 within the criminal code to help offset that chilling effect and the slippery slope that was just outlined?
Écoutez, la section...
Well, listen, Section 45 needs to be taken with a grain of salt to a certain extent, to the extent that even if physicians might not be charged that there was no informed consent, for example, there needs to be certain indications. For example, in obstetrics, either things are going perfectly well or they're not going well at all. Perhaps you might enter a room where the female is bleeding. It might not be when labour has begun, and yet there's a delivery occurring in another room at the same time. So everything's happening at the same time. Unfortunately, the delivery room is a specific area because there's always hanging in the balance between life and death. The baby's either going well or not going well. So Section 45, well, we're pleased that there are protections when it comes to medical decisions included in Section 45. But the fact remains that the onus is still on the physician to gain the confidence and trust of an individual that you've just met 5 minutes ago. Listen, you're bleeding, you're unstable, you may die. We're going into the operating room. I'm going to do my best and utmost to save your uterus. That's not informed consent. That's a horror film that's being described to the woman in the blink of an eyelid. So we understand the rationale behind this, but the physician will always, at the end of the day, have to justify themselves and potentially second-guess themselves. All of the eventualities will be discussed. You know, there are evaluation and assessment committees where these kinds of scenarios are reviewed. Have you met with the family to explain to them what is occurring? Has an intermediary been designated? We're always trying to enhance our standards of care. But unfortunately, these terrible situations still occur. And it's my belief that Section 45 is full of good intentions. However, the fact remains that in a situation where a physician may have not had an opportunity to meet with the patient or their family ahead of time, and they are faced with an unexpected situation, well, there may be second guessing in the decision making. It may cause delays, and it might not cause a death, but it might mean that multiple blood transfusions are needed or more extensive surgeries than would have otherwise necessarily been required.
For that elaboration. Am I, just given what you just said, Dr. Francoeur, do you see informed consent as part and parcel, as a necessary condition within Section 45? Is that what you're saying, that when we consider Section 45, you have to have that additional requirement of informed consent?
Dans une situation d'urgence,
Well, in an emergency situation, one can't always get informed consent. Sometimes it'll be an emergency, but let me tell you about a clinical situation that occurred last year. There was a woman, she was a new immigrant, she'd come from India. She spoke an ancient language that was kind of like Punjabi. We reached out to interpreters, none were available. She was in early labour, and I couldn't open up the stomach of a person without them understanding what I was about to do. And finally, we found an interpreter in Vancouver. Everyone got on the phone so that we could at the very least, explain to this woman what was occurring. The baby was premature, that she was bleeding. Listen, there were so many risks and perils that she faced. And most obstetricians and gynecologists, well, they do their utmost to provide care to these women. They're very careful about explaining the situation, but sometimes we're faced with scenarios where it's impossible for us to ensure that the individual has understood the potential consequences of what we are doing, and where we quite simply don't have the time to go into further detail or even postpone the procedure.
Lawyer,
Thank you.
followed by Senator Simons.
I just want to continue on with that a little bit. So what you're saying is that informed consent is part of Section 45?
non, ce que je dis, c'est que le...
No. What I'm saying is that when there's a procedure that's going ahead, we try to explain the possible consequences to the patient. But what I'm saying about Section 45 is that it's there. It's not a protective measure per se, but it will prevent situations where detailed informed consent is not provided, and in that sense it's a level of protection for the physician. But I apologise if I didn't clearly explain myself.
Bill S-228 targets only sterilizations without free and informed consent. If the patient initiates the request and valid consent is obtained, physicians don't have anything to fear. Section 45 still protects doctors acting in good faith in emergencies. That's the key reason this committee amended and simplified the original bill of S-250 from last year. I have a other question that I'd like to ask you about. It's about, what are the chances of having an ectopic pregnancy in both tubes? You had said, you had mentioned ectopic pregnancies in tubes. So that would leave the patient sterile. But generally, doesn't it usually just happen in one tube? You don't have them two at a time in both tubes?
Oui, mais la plupart du temps, la grossesse ectopique...
Yes, but in most occasions, the ruptured ectopic pregnancies occurs in the best tube because the other tube is blocked, and that is why the pregnancy occurs in the less ill tube, if you'll permit me the expression.
Sterile.
Oui, tout à fait.
It could, yes.
Yes, indeed.
Have you heard about Katie Bear? Katie Bear, there was a CBC article done about Katie Bear, who had been sterilized against her will when she was 21 years old. She had an ectopic pregnancy 20 years later, and she had her tube removed. It was an 8-week ectopic pregnancy, so it was very much an emergency surgery. At the same time, the doctor assisted her in this emergency procedure, knew her background, that she had a tubal ligation without consent 20 years before, and they talked about it after, and she had a reanastomosis done, that clip removed, and she had a less than 5% chance of having a baby, and she did. Baby Sage was born in March. So it's not, not everybody has double ectopic pregnancies as is left sterile. So I just want to make that clear, that it's usually in one tube, and it doesn't always leave somebody sterile.
Vous avez tout à fait raison. Mais,
Well, you're entirely right. But when you don't see the state of the two tubes, well, you can't be 100% sure. But the conservative treatment is the best choice, i.e. The ectopic pregnancy, and to not touch the other tube at all initially.
One more thing I'd like to talk to you about. You had said that S-228 is going to really have a chilling effect, and doctors are really going to be thinking about, when they're in emergency surgery, whether they should do it or they're going to be subjected to it. But we already have assault provisions in place, and we have Section 45 in place. Did they say the same thing about the assault provisions that are in place?
I think it comes down to the criminalization aspect, and to have, that so explicit. As I said, we said right from the beginning that we disagree. It is not right. And I think where we're coming from is that there is such a lens now on women's sexual and reproductive health rights. And this is this is something that's going to bring more spotlight. And I think the other thing is, we know physicians know when they obtain informed consent what that includes. But we recognize more needs to be done, no question. And I think one of the things here is that, we have Section 45. We know this is illegal to do this. But where we need to go is to have, I think there needs to be such an opening up of public education, and more particularly in physician education. What is conformed consent? How do you actually get that? In many places, when you go in all places now, there's what's called timeout. It's like an airline checklist. And one of the things is you need to ensure before you move forward in anything that you have that signed and done. And I think there needs to be more education, like I said, and we need to look at our colleges as well. What is their role in this? There are, 10 colleges in the provinces and 3 in the territories, and we're not hearing from them on this. And they are actually the body that should be addressing these issues that we're speaking about from that perspective, from physicians doing what is wrong and illegal. I think for me, as I said, it's women's sexual and reproductive health rights is being, it's front and center in many things now. And I think what we want to do is to make sure that we protect that access for women, but we also address all of the things that need to be addressed in the informed consent process, and working with women, particularly Indigenous women, to make that happen, to sit down and go through this and say, what do we need to ensure that all women are protected, and cared for in the way that they should be. So I think that is part of it, is this lens on women's sexual and reproductive health rights, and again, something that potentially causes a withdrawal or a question of access for women.
Okay, thank you.
Senator Simons, followed by Senator Saint-Germain.
Thank you very much, Mr. Chair. And thank you very much to all three physicians for being here today. I share very much your concerns about what happens in an emergency situation if doctors are second-guessing themselves, even if they have the news stories from the United States in the back of their minds. And granted, this is not the United States, but if you're taking a moment to pause to think, am I going to be criminally charged, it's very different than thinking about, might I face sanctions from the college? But I want to talk about a different kind of chilling effect. I am old enough to remember hearing stories from my mother-in-law that when she sought a tubal ligation after 5 babies and 7 pregnancies, that she was required to get a psychiatric exam. When my own mother sought a tubal ligation a couple of years later, she was required to get a signed letter of consent from my father, something she never let him forget. And what I worry about is that in our very good faith efforts to try to protect Indigenous women, that we may be reducing access for Indigenous women and other women to necessary gynecological health care, that doctors may be disinclined to provide tubal ligations to women who ask for them, disinclined to recommend hysterectomies for women who are suffering from gynecological conditions where a hysterectomy could be therapeutic, that they may be very disinclined to offer gender-affirming care if there's a concern that 6 months later the patient could come forward and say, I didn't really understand, I really regret my decision, I wasn't properly informed. So I wondered if you could speak to that larger concern I have about whether doctors might be more likely to hesitate to offer therapies or to provide therapies if they're concerned about criminalization of what are basically routine medical procedures.
Thank you for those points. And I do agree, and that was one of the points that I had made up in my statement, is that, and again, I hate to keep going back to it, but when you criminalize something, it takes on a completely different lens. And quite truthfully, in having discussions, there are physicians, I think, that will step away. They will step away from offering tubal ligations in the fact that there is nothing else in medicine that will end in a possible 14-year prison sentence. And I think, again, when you put that criminal lens over it, it does cause physicians to really pause and move away. And we alluded, again, to the U.S., that's what's happening. That is what's happening. Women are coming in with, an ectopic pregnancy. They will not help them if there's a fetal heart because it's criminal for them to do so. So when you put that lens over it, I think you will see physicians step away and say, no, I'm not going to do this anymore because I can't take that risk. And I mean, you can do, and this is where I go back to that informed consent and what we need to do to improve that so that the public, women, particularly Indigenous women, and physicians are all reading from the same page. They all understand what that consent is and what are the safeguards that we need to put in place so that when we move forward and that procedure happens, everyone involved, not just the physician, not just the patient, but everyone who's in that operating room or wherever it's taking place, all understands that this checklist, everything has been covered and consent is obtained yet again before the procedure is started. So the criminalization of anything puts a completely different lens on, and I do worry. And doing the work that I do, I have seen the devastating consequences of the criminalization of some of the things in the U.S. Women are dying. So I think access will go down to this procedure and possibly others.
May I just chime in, please? Yes, please. Well, you've raised an extremely important point. With all the disinformation that is unfortunately circulating currently. Women have so much trouble accessing our healthcare system. Oftentimes they'll turn to social media to get information. And let me tell you that Donald Trump has given us headaches this week with this whole business of Tylenol. We are forced to take a stand to ensure that women in Canada, because they're against vaccinations for pregnant women and Tylenol for pregnant women. This is unprecedented. But at the SOGC, we've held 35 interviews over the past several days to ensure that women in Canada who do take Tylenol if they have a fever, but to come back to the gynecological issues. What women see in social media, well, the upshot of what they see is that they're so afraid of being sterilised. And they'll second-guess themselves, they'll postpone procedures. For example, black women who are have 3 times more likely to bleed because of certain physiological conditions. They'll have to go and get blood transfusions. They won't be functional in the sense because they'll be afraid of surgeries taking place that are without their consent and that they might end up sterile. Because that's where this is what we're dealing with, the fallopian tubes, the uterus, and it's very difficult to separate each anatomical part of a woman. And when there is this seed of doubt that is sown on the basis of misinformation, and when they are when physicians are afraid of being sued, well, this is a perfect storm. Women are going to be left to their own devices with no solutions, and we can provide better care to women in Canada than that.
Pass.
Thank you.
Time is short.
Senator Saint-Germain.
Senator Salmons, thank you, Mr. Chair. Alors, merci évidemment à vous trois d'être.
Well, thank you to the three of you for being here. Now, in our conversation today, there's a level of confusion in terms of our understanding of the bill. Section 45 exists for medical emergencies, already protects physicians. What this bill adds, Bill 228, is an assurance that women's rights that have been abused due to unnecessary medical procedures that were not urgent, that did not respect the notion of free, prior and informed consent of patients. And I'd like to hone in on this word patient here. We're talking about the reproductive rights of human beings here. So what this legislation adds is a certain respect for women's rights. And you have both alluded to this. Yes, we need awareness building among not only just women, but all human beings in terms of their reproductive rights, but also in terms of the protocols that physicians have to live by so that they have some assurance that when they are required to obtain prior informed and free consent, how do they go about it? What does it mean, example? Now, I don't want to get into the weeds here with specific medical examples. Let me just give you an example about MAID, medical assistance in dying. It's very complicated. I was in Quebec at the time debating this issue, and it was agreed that we needed to have training and protocols for physicians. And this is a huge issue. So I'm asking the question of you. If this legislation comes into effect, how can the Canadian Medical Association ultimately contribute to helping physicians understand that they have their ethical obligations, but they'll also be protected, and so that they are reassured that they can practice medicine without fear of criminalisation, but being fully conscious of their rights and their obligations when it comes to the rights of patients? Response. Well, thank you very much for the question. Senator Boyer knows ahead of time what I'm going to say here. My colleague talked about the timeout, which is a procedure that takes place before a surgery. And that is a result of surgeries that were performed on the wrong leg, for example. These are safety nets that we've put in place, and we believe that the same can be done in the case of all sterilising surgeries. It's easy to have these. All we need is funding to produce videos in all languages so that women can explain in their own mother tongue. We need rules in place. Sterilisation must never be performed if it was not discussed during pregnancy. There needs to be clear notes in the patient's records, medical records. There needs to be consultations, and it has to be discussed again on the day of a potential sterilisation procedure when a caesarean operation is taking place. So this awareness building needs to happen writ large, and we've referred a lot to First Nations and Indigenous women who are disproportionately affected, and we know that these things are happening to them, but we need to find ways to ensure that this no longer occurs. But in the case of women, all women in Canada, there's issues with language in Canada. Sometimes we have to go through the child because no one else, there's no interpreter, no one else speaks the language. So we need consistent guidelines across Canada, such as this time-out notion, for example. So that is required in operating rooms in many places. So you'll acknowledge that if this legislation passes, if these protocols apply across Canada, and if women are educated and their rights are upheld, the upshot of the legislation will be to prevent, to the extent possible, the documented incidents that you've referred to. Response. Well, I hope that this will occur even if the legislation doesn't get through, because it's absolutely crucial, given all of the women across Canada who have suffered, who've told us their stories, who've told us about their personal lives. And we've testified here on a number of occasions. We can no longer pretend that this problem doesn't exist. We need concrete solutions, and in our opinion, criminalisation is not the only solution. Thank you.
Dr. Burnell, Senator Saint-Germain mentioned the Canadian Medical Association. Do you have any comment on the issue that she's raising about protocols and education and the role of the Canadian Medical Association?
Thank you, Mr. Chair. First of all, I would just like to thank Senator Batters for her correction on the information, and to Senator Boyer for her work in this before I start. So the CMA supports this new bill. I think it's the first step in recognizing the issue. As a physician, I'm sensitive to what has been raised by my colleagues. The most important step, if this bill should come into legislation, is really the education and training of all of our staff, and discussions with our patients of building that trusting relationship. And we may need to expand the more, the least common side effects or possibilities when we're doing that, just to make sure that we're comfortable, that the patient and the loved ones with them are there. That really is just starting the dialogue and empowering women to make choices, to be involved in the discussion, and that we respect their ultimate decision.
Dr. Murphy-Callbeck, you'd like to make a comment?
Just one comment. I think it needs to be said that regardless of this legislation, if it passes or not, there's a need to follow through on all the things that we've discussed today. So I put that out there, that regardless of where this legislation goes, that we need to work with our partners on this, regardless, like I said, if it goes or not. And I think that message needs to be very clear to all, as well as the colleges and the CMA, that we all have a role in this. And I would just say that from the perspective of the SOGC, we would prefer to go forward doing that without the criminalization, given the discussion today and what some of the potential fallout is from that. Thank you.
Thank you. I'm going to exercise my discretion to make sure all the questions that get answered. So we've got Senator Pate, Senator Clement, and Senator Wells.
Thank you very much, Mr. Chair, and thank you to all of our witnesses. My question is for Drs. Francoeur and Murphy-Callback, but I'd also be interested in Dr. Burnell's perspective on this. The root of this this issue and the rationale for bringing forth this legislation is very clearly rooted in historical and ongoing discriminatory attitudes and practices by the medical profession. And at the root of that is clearly racism. We know that this has happened to Indigenous people, but also other racialized folks, particularly those of African descent, as well as those with mental health and other disabilities, poor people, and in an area that I've worked a lot, prisons. And so we know that's at the root. You've been very clear about why criminalization is not the answer, and that's often the position that I'm putting forth in many issues, because from where I sit, we often see criminalization resulting in a lawyering up of not just professional bodies and individual doctors, but also those whose aim is to protect, and not necessarily for good reason, these kinds of discriminatory practices. So if you were in the position of Senator Boyer, what would you be proposing at this stage? And that's for both groups.
I would just like to comment first, and we met Senator Boyer many times, and we know where our heart is, and ours is not so far. It's just the how to, we're going to get to the same goal and be able to reach a consensus. And I'll just give you an example. Where's going to be the limit? Let's say, because I'm a pediatric gynecologist, the biggest cancer in teens is leukemia. What happens when you have chemo? Dr. Burnell knows, she's an oncologist, so your ovaries done. Not all the time, but many times. And so what are you going to do with, these women, that young women, you just think about surviving, and then you get older, and then you realize that you're not going to be able to have a baby because your ovaries are not functioning after the chemo. So it's not a surgery, but it's a sterilizing medical treatment. Where was the consent? And which was the child? You save her life. So it's always, when we talk about criminalization, where is the limit? Where does it stop? And it's, from my perspective, it's opening traps that are going to put a lot of doubt in many women that, there was no other ways. And it's really, we've seen this situation, and it's really hard to kind of go back and unknit all the, the past history. And it's different than what happened with the Indigenous women, totally. But it's going to have an impact too. So that's why we are recommending that there is no criminalization, but nevertheless, we have to find a way to make it stop. And we think that, education and having standardizing, making part of the hospital how to. This is why Accreditation Canada is doing when they come. They make sure that people wash their hands properly, Rights and consent should be part of all these decisions, because the reality is that when you sign an informed consent, I don't know how many lawyers are in this room, but you have 2 pages of fine print that most people don't understand. We call it an informed consent, but if there was a post-test after you sign it, a lot of people would fail because they don't realize what they're signing. So the consent is more to see what's going to be the procedure about, and after, what are going to be the consequences with it.
I'll be just a bit more, I think, keep it on a very simple level. I would want us to move forward with many of the things that we had put forward with Truth and Reconciliation. And I think, I would hope, again, regardless if we move forward with criminalization or not, that we take a step back and we say, you know, what do we need to do? What do we need to do as physicians? What do we need to do as society and public government to address this issue, but all of the other issues that we've talked about today? Because if we move forward with criminalization, and that's our hammer, but we don't put anything else in place, I think we've failed everyone. We truly need to address all of the things that we have talked about over the course of time in Truth and Reconciliation. And I just see that if we criminalize and we leave it, we haven't fixed anything. We're still in that place where we haven't actually sat down and talked about how do we right these wrongs? How do we work with Indigenous groups, marginalized groups, all women and people, and say, how do we fix this? Because criminalization is just going to be for those rare cases. It doesn't fix that systemic problem. So I see it more criminalization or not. That's just one part of this. We have to address all of the other things that we've brought up today. Thank you.
And Dr. Burnell, you've spoken in favor of this. The provisions already exist in the criminal code that criminalization could have occurred and has not. How would you, same question, but add to that, how do you see this changing that practice at the prosecutorial and at other levels?
So thank you. So we support this legislation, and I think that this new amendment helps to deal with the previous concerns. I would fully support the fact that there needs to be those other processes of discussion, education, creating culturally and psychologically safe spaces for individuals to discuss this. Many of these decisions are foreseeable, and what the other physicians are concerned about are really the emergency, where they're maybe not anticipated in that. We feel that commenting on Section 45 exemption provides those safeguards.
Thank you.
Thank you. Senator Clément.
Thank you, doctors, all of you, for your careers, not just for being here, but for the work that you've done. I fully endorse Senatrice Saint-Germain's question about training. I wanted it to go further because I think we're often at this committee criminalizing things because there is no trust. Black women, Indigenous women, we don't have trust necessarily in our institutions that are there to protect us. And so we need full transparency in terms of the training that is being done, actually being done now. Is it current? Are you trained in medical schools? Are you trained to keep up with the legal challenges that are being posed today at this very moment? There has to be clarity and transparency with communities, with le public général, monsieur et madame tout le monde, so that we have trust. Otherwise, this is the process that we have to address issues, is to go to the criminal code. Dr. Murphy-Colbeck.
If I can comment, and I think it goes back to what I said earlier. As far as the training, I think, as we had said, we need to improve that, not just in obstetrics and gynecology, but the process overall of obtaining informed consent. And I think medical assistance in dying has helped us a bit with that, because that is one, there's sober second thought. There's all kinds of things about that. But I think going back to why we're here today, if we're going to do training and we're going to look at informed consent and how do physicians, and not just physicians, other allied healthcare professionals obtain informed consent, I think we need to strip that down. I think we need to start and say, okay, what has led us to this? And that would be that we haven't had those conversations. We haven't brought in those groups that we need to. and say, okay, let's work together. And that's, I think that's the biggest thing about what I bring today is that we need to break down the barriers, and we need to actually have those conversations, and we actually need to look at our training. And I will say that medical schools, this is coming much more to the forefront, but it needs to be within the entire system, and it needs to be through the trajectory of my career. If I learned it in medical school, but I'm still, here I am at, I won't say how old I am, I still need to go at that. I still need to have that CME. And that's where I think we need, and I'll stress this again, is to bring in our partners, the women that we actually care for day after day after day, and say, how do we work together? What do we need to improve this so that we are all on the same page and we all understand one another and where we're coming from when we do this process? So, I think, again, irrespective of this bill, these are things we should be doing anyway. We should be having those conversations and bringing our partners into the process. And the SOGC is we're moving forward with this. But there's a lot of work to be done, and it can't just be done by one group. It has to be within the system itself.
Not just should, but must be doing.
Must be, absolutely.
Yeah, thank you for that.
Sorry, go ahead. Did you?
Oh, just a quick comment. So SOGC has an international project, and we have an education program that we give in Africa, in Haiti, and around the world called Alarm, and we try so many times to have the support to do Alarm North with the community, because it's a training with all the healthcare providers, the midwives, the nurses, the community, the elders, and but we're not able to implement it here. And, that's most of this focus is on respectful care in labor and delivery room and how you should be treating women. And we're more successful in countries sometimes where women have barely no rights. And here in our country, we just kind of push it on the side. So we just need to put it under the spotlight.
Thank you. Dr. Brunel, did you want to make any comment on the question of Senator Clement?
So I would suggest that this legislation is really sort of the last safeguard in a process. And I would agree that education, training, discussion amongst all of our women, their choice and their understanding is critically important. This was proposed by Senator Boyer just because she was having so many patients bring this to her attention. And I would hope that if it was passed, it would never be used, because we've done such a good job in providing education, discussion, and building those trusting and safe spaces.
Thank you. Senator Wells, you're the last questioner.
My questions have been answered. Just a thank you to our witnesses and for the very informative dialogue from everyone and our colleagues.
I think we all share Senator Wells' comments. Thank you very much, witnesses, for participating here today and informing our committee on this very important issue. Thank you to all. We'll now suspend for